Hi everybody and welcome to Module 3. In this module we're going to be going into kind of a deep dive with the diagnosis and assessment of autism spectrum disorder. Particularly we're going to focus more on the diagnostic part of this disorder, but I will talk a little bit, especially towards the end, about the assessments that are done. There's really three main types of assessments that are done. So the biggest part of this module and really the biggest takeaway is to know what those assessments are, but to really be able to kind of understand the process of diagnosis and what the main diagnostic criteria are. Alright, so let's go ahead and get started. So first things first, some of the key elements of autism spectrum disorder. You'll see as we go through, I'm going to go in a lot more greater detail. I'll talk about the difference between two main diagnostic manuals, but essentially at its core, there are two major kind of categories or groupings of characteristics of impairments that really kind of define autism spectrum disorder. The first is disruptions or impairments to social communication, and the other is disruptions to social interactions. And oftentimes along with that, kind of as a sub-point, that these disruptions to the social communication, social interactions, oftentimes also include kind of restricted behavior, like a limited focus of interest, maybe repetitive behaviors, things like that, restricted interests, restricted activities that the child or adult are usually interested in. In order to qualify for autism spectrum disorder for the diagnosis, the impairments have to be present early on in childhood. So this isn't a disorder that, even though adults have it, adults don't develop it. Right? It's a childhood disorder. It's something that happens very early on in childhood, and then what happens is it carries on into adulthood. Now, that being said, can there be an adult diagnosed with it that wasn't diagnosed as a child? Yes. But then what we look at is, when did the symptoms start? And they had to have started early on. The degree of impairment distinguishes individuals previously diagnosed with the separate disorders of autistic disorder, Asperger's, pervasive developmental disorder. I'll talk about this a couple more times, but remember, after watching the video that I did about the history of autism, that all those kind of historical subtypes of autism, like pervasive developmental disorder, Kanner's type autism, there's a bunch of them. Those aren't really actual diagnostic disorders anymore. You still hear people referring to them, but you won't be diagnosed with it, at least not by a legitimate clinician. Now it's part of autism spectrum disorder, and all of them just kind of fit within that larger umbrella. The term disorder in autism spectrum disorder, ASD, does suggest that the shared symptoms represent one core problem. Again, though, this is kind of difficult, and it's a little bit controversial because, one of the main reasons is science really hasn't determined yet what the cause of autism is, or if there even is a cause versus several causes, which we talked about extensively in the first module that I did, that we went over. But now you probably kind of understand the reasoning behind this, right? It can be kind of difficult for us to view it as like a disorder because we think of it as a disease or something like that, right? First off, autism isn't contagious. Autism spectrum disorder isn't contagious. But, people kind of have that mindset also that you hear disorder, that's sort of like, oh, well, it's got to be caused by something, right? And then it causes this. And we're not necessarily sure if that's true or not yet. So try not to think of it in terms of that. It's quite unique from a lot of the other disorders that we deal with. And indeed, the same can be said for a vast majority of mental health conditions as well. Alright, so there are two main manuals that we really look at. The DSM-5 TR, so DSM, by now you probably know, stands for the Diagnostic and Statistical Manual of Mental Health Disorders. It's published in the United States by the American Psychiatric Association, not the American Psychological Association, even though I know it's confusing. They both are known by the APA. but the American Psychiatric Association are the ones who actually published the DSM. The DSM-5 is the 5th edition. TR is it's in the process of being there's a DSM-5, now there's a DSM-5 TR. Probably in, I don't know, 5 to 10 years, there's going to be a DSM-6. It's just constantly being revised, new editions coming out, information changing, and you saw that in that lecture I did on the history of autism. The other manual that we use is the International Classification of Diseases, or ICD, and it's currently in its 11th edition, so it's the ICD-11. The DSM is published by the American Psychiatric Association. The ICD is published by the World Health Organization. The standard, and I'm sure you've probably heard this before, is that the DSM is really more American-centric. So some people argue that there's a little bit more cultural influence from the United States in the DSM, whereas the ICD is intended to be used internationally, so there's a little bit less of that cultural, some people would say bias, some people would say influence. The DSM probably has the longest history behind it. The ICD, interestingly enough, or at least I find this interesting, maybe many of you won't, is that the ICD isn't really used to diagnose in the United States, at least speaking from a psychology standpoint. The DSM is the gold standard for making a diagnosis. But the interesting thing is, even though we're diagnosing off the DSM, in order to bill for insurance, the codes all have to go through ICD codes. And in fact, the DSM-5 TR, now along with the actual diagnoses, list the ICD codes within them. Again, I find that interesting. You're probably like, that is the least interesting thing somebody ever said. So my apologies on that. Alright, so there are a little bit of differences here between how the DSM categorizes autism spectrum disorder and how the ICD does. Both of them do list it as a disorder. Both of them do kind of have this idea of there being a spectrum of disorder, right? So there's different features. No two people have the same features, or at least exactly the same features. So with the DSM-5, they maintain that term of autism spectrum disorder. The ICD does as well. However, the ICD, the language in it, is a lot more expansive in the fact that it still emphasizes that even though we have the spectrum of a disorder, there are many different kind of subtypes, if you will, right? The DSM doesn't really talk like that. It just says one disorder, but it manifests in different ways. The ICD is more like, it's one disorder, but there definitely are different types of ASD. With the DSM, it groups symptoms into two main domains: social communication and social interaction deficits. And in fact, I'm going to be going into this in greater detail in the next couple slides, where we'll really talk about specifically what the DSM says in its diagnostic criteria. With the ICD, it divides symptoms into deficits in reciprocal social interaction and communication, restricted, repetitive, and inflexible patterns of behavior and interest. Now, this is kind of a moot point because, as you'll see in a little bit, the DSM also covers that information. It's just that the ICD isn't as clear in its division of these two main domains. It actually has a couple of different ones listed. With the DSM-5, it includes specifiers, and again, I'll show you that here in a little bit. So a specifier is kind of what it sounds like, right? So basically it's a label placed after a diagnosis that distinguishes that diagnosis as specifying some kind of specific cause, pattern, or how it's manifested and how it may be different from other people that have the same disorder but don't have that specifier. It's going to make a little bit more sense in a little bit when I show you the slide. The ICD-11, though, actually does not really include those specifiers that much. And in specifically, this is one of the big differences, kind of wink, wink, nod, nod, big differences between DSM-5 and the ICD-11. The DSM-5 talks about severity levels, right? So it's level 1, level 2, level 3. And again, we'll talk about that here in a little bit. The ICD doesn't really distinguish severity levels. It asks that as you're making the diagnosis that you kind of factor in the level of functioning that a person with ASD has in each of the little domains. So how is their functioning in social communication? How is their functioning with repetitive behaviors? How is their functioning with social interactions? But it's not as clear cut as 1, 2, and 3. So in some ways, people have kind of argued that the ICD classification on this is a little bit more flexible, whereas the DSM, when it comes to severity levels, this isn't my words, but some people would argue that it kind of pigeonholes kids into these little artificial categories, or adults also. All right, so moving on, before we actually get into the DSM criteria, a couple different terms that I just want you to kind of know, feel comfortable with. You'll see it when you go over the DSM, and of course there'll be a link for the DSM for ASD, at least that specific section, in the course as well. So nonverbal communication, when we refer to that, we're talking about the act of conveying information without actually using words. So some people can say that's body language, and of course that's nonverbal communication. Is a great example of it. So if I'm sitting here and I have my arms folded, some person may convey that in a different way. That maybe I'm standoffish, or I'm angry, or I'm upset. Maybe that I'm cold, but that's nonverbal communication still. There's other forms of nonverbal communication. I'm sure we're all familiar with a specific hand gesture that oftentimes can be conveying of meaning, and of course I mean the thumbs up sign, right? Good old thumbs up sign. There's another one too, but I'm not going to do that on camera. All of these nonverbal communications. Echolalia. So echolalia is the act of repeating what someone else says. I know what that sounds like, right? It kind of sounds like the gamey kit that kids play, like, just mimicking somebody else. That's not what we're talking about with echolalia, though. Echolalia is actually an important process when we're learning language, in that we first hear the words around us. And in fact, when we're infants, even before when we're infants, when we're actually in the womb, we hear the words our mothers are saying. We hear the words of people around us as we're born, as we're infants. And we continue to hear these sounds, and we start kind of mimicking them. We start trying to imitate them, right? That's echolalia. Oftentimes what we see is that people with autism, that children with autism, very young children with autism, have some kind of impairment with that echolalia, and it probably ties into the social connections and the disruptions with their ability to connect socially, that by doing that, it impairs this echolalia because they're not interacting as much and not paying attention as much and not focusing as much, and they're not wanting to repeat those words. And then that leads to disruptions to the language. But that's kind of beyond this. Just know what echolalia is. Social reciprocity. So social reciprocity is kind of like the back and forth that happens in social settings that most of us just kind of take for granted. Some of this can be kind of gauging things like how to talk to somebody, right? You kind of see somebody beginning to motion like they want to talk, and it's your cue to stop talking and let them talk. And that's that little kind of back and forth. Again, these are things that most of us kind of take for granted, and we don't really even think about. It's almost like done on a subconscious level of processing. But for people with autism spectrum disorder, the social reciprocity, oftentimes kind of goes over their head. They don't even realize it. They don't understand it. If you try to explain it to them, it's something that is very difficult. Idiosyncratic phrases. So idiosyncratic phrases are a unique way of communication that features words and expressions distinctive to an individual or group, setting them apart from common usage. So all of us kind of have idiosyncratic phrases. I remember way back, I like to joke it's in a previous life that I actually used to work in law enforcement. And in that setting, if you were to call in sick, we would call that baning in, right? So if you called in sick and be like, oh man, I heard you baned in yesterday, you feeling okay? I don't know where it came from. I know how it sounds, right? It's not what it sounds like, but that's just a phrase that we would all kind of use, and we all knew that. But you mentioned to somebody outside of that setting, and they're like, what? What did you say? You banged in? Like, that sounds so weird. Well, that's an idiosyncratic phrase. This is where it's a little bit different with people with autism spectrum disorder, especially with children with autism spectrum disorder, is that sometimes they kind of come up with their own words that sound right. I mean, it sounds like English, but it's not the right word or it's not in the right usage. So I'll give you some examples of this, right? Say a young child plays outside frequently with their dog, and the dog's name is Sparky. That child may start now calling outside, going outside, being outside, the outdoors, Sparky, because they so associated it with them. And part of this is part of normal language development also. I just want to point that out. So using that example, I'll say how typical development occurs with language. Say the same child doesn't have autism spectrum disorder. They're playing with their dog. They know their dog's name is Sparky. Everybody in the family is calling the dog Sparky. Early on in language development, it would be perfectly natural for that child to probably start calling all dogs Sparky, because they don't understand the difference between Sparky is the name of a dog versus Sparky is what a dog is, right? And that's the name for it. Because it's not like people in the house are saying dog all the time, right? They're calling the dog by the name. Hopefully that makes sense to you. It's not too confusing. With children and adults with autism, those idiosyncratic phrases kind of go that step further from what would be considered typical use of those idiosyncratic phrases. Stereotypy. So this is another one that we actually do use if you're neurotypical. However, neuroatypical individuals, especially people with autism spectrum disorder, kind of take this to a whole different level. So stereotypies are semi-voluntary repetitive movements that are a prominent clinical feature of ASD. Sometimes this takes the form of things like hand flapping, sometimes like hitting yourself, not like in a I'm going to hurt myself thing, but just sort of like tapping your chest, doing things like that. Now I say this is a feature that many neurotypical people have, and the way I like to explain it is like this. Have you ever had an encounter? Like I'm thinking back to, maybe a little while ago, say this is probably several years ago, where I was on the phone with like a call center, and they didn't understand me. They kept giving me the runaround, and I'm just getting so pissed. And finally, I'm like raising my voice and my hands moving like this, as if I'm trying to be emphatic and like really make my case, and I'm moving my hand. Some people would consider that to be kind of a stereotypy, right? It's a way for me to kind of get out that aggression, but it means nothing to communication if I'm talking to somebody over the phone, right? The difference is with individuals with ASD, sometimes they'll do these very frequently. And it's worth noting that just like how I'm sitting there and I'm talking with my hand and I'm being emphatic and waving my hand around because I was frustrated, it kind of made me feel better. Oftentimes, individuals with ASD will engage in these stereotypies, and it actually will make them feel better. It'll actually kind of like ease the tension, the anxiety, whatever they're dealing with. It's worth noting too. So some people say, well, what about like individuals with OCD, where they may organize things or they may have certain like rituals that they do. Like I know some person who had this condition as a client that, before they would, say, open their car door, they would turn in a circle 3 times and then open it. Isn't that a stereotypy? Not really, and the way that we would distinguish that from what we would see with somebody with OCD is that somebody with OCD, their rituals, their behaviors, doing that actually is kind of causing them anxiety, and if they don't do it, it really causes the anxiety to go up. Oftentimes, though, individuals with ASD, it's not really with that kind of component necessarily anxiety. It may make them feel better. They may enjoy doing it, but it's not necessarily on that same level as somebody with OCD. The last one on here is perseveration. So perseveration is the repetition of a behavior or thought pattern beyond a reasonable point. Sometimes people even extend this out to like language, where a person with ASD may kind of continue with something well past where it would be appropriate. So like for speech, I know somebody who would constantly say, that's how the cookie crumbles. All right, so they're talking, and say they're talking about the football game last night, and they're saying that's how the cookie crumbles like 10 times, within 15 minutes or something. You're like, wow, that's a lot. Like, you're saying that a lot. Oftentimes, with repetition of behavior, you'll kind of see where they'll engage in these certain little behaviors, not necessarily like stereotypies where it's just like hand flapping, but other types of behaviors, and they kind of hold on to it where they'll keep doing that over and over and over. All right, so going into the DSM-5 TR criteria for ASD. So the first two things, these are the two big categories. Remember what I just talked about within the DSM? So the first two main categories is social communication deficits and engaging in repetitive behaviors. I'm going to go into these in the additional slides that'll come after this because there's more to it. But for the first criteria, and this is actually how it shows up in the DSM, is that it has social communication deficits, which are under kind of like criterion A. So these are persistent deficits in social communication and social interaction across multiple contexts, as manifested by all of the following currently or by history. You're thinking, well, what's all the following? All the following like what's listed on the slide? No. I'm going to go to the next slide here. So all of these must be present, right? These all fall under that criterion A. The first one, social emotional reciprocity. You have to have deficits in social emotional reciprocity that range from abnormal social approaches and failure of a normal back and forth conversation, all the way to reduced sharing of interests, emotions, or affect, as in like emotional affect. Like if you're telling somebody a sad story about how you just had to put your cat down, and the person is just kind of like on their phone, they're doodling on a piece of paper, they're laughing, they're doing, right? It's kind of a weird little affect. They're emotionally not responding how you probably a typical person would. And then finally, failure to initiate or respond to social interactions. This isn't 100% of the time, right? It's just that you have difficulty with that, and it's causing a major disruption or a deficit in your life. So this must be present in order for a diagnosis to be made of ASD. Nonverbal communication. Deficits in nonverbal communicative behaviors used for social interaction include poorly integrated verbal and nonverbal communication, abnormalities in eye contact and body language. I'm going to talk a little bit about that eye contact thing, though, later on in the presentation. Or a total lack of facial expressions and nonverbal communication. So, some aspect of that must be present in order for a diagnosis of ASD to be made. And then the final part, under this criterion A, under the social communication deficits, is understanding relationships. So the person has to have deficits in developing, maintaining, and understanding relationships, and that this manifests as difficulties in adjusting behavior to suit various social contexts, sharing imaginative play or making friends, and an absence of interest in peers. Sometimes you'll see where this will come up, where for young children, you may be in a room where other people are talking, they're doing whatever, and the kid will just kind of be in their own world. Maybe they'll interject a few times as the other kids are talking and just talk about something completely unrelated, right? So maybe the kids are talking about school, they're talking about what they're going to have for lunch, and they're going to talk about playing in the jungle gym, and a child who has ASD is just going to keep talking about Legos or something along those lines. All right. So all three of these have to be met, going back a slide again, under this criterion A for the DSM. All falls under that social communication deficits. All three of those must be present. Next criterion, B, repetitive behaviors. So it involves restricted, repetitive patterns of behavior, interest, or activities as manifested by at least two of the following. Currently or by history. And again, that currently or by history means currently you're doing this. I can see it. If I'm a clinician and I'm trying to diagnose you, I can see you doing it right now. By history, typically the way this works is somebody saying, oh yeah, it started way back when they were 3, 4, 5, all the way in childhood. or the person talking about how they were like this. Because again, remember, for a diagnosis of ASD to be made, had to have started in childhood. So let me tell you what the specific subtypes are for this, right? So remember, 2 have to be present. So let me go ahead. Behavioral patterns in ASD. So again, in order for a diagnosis to be made, a person must have 2 of these 4. So stereotyped behaviors. Remember, we just talked about stereotypies. So stereotyped or repetitive motor movements, like muscle movements, body movements. Use of objects or speech, such as simple motor stereotypies, lining up toys, or echolalia. There's some of those key terms that you need to know that I just covered. So that is 1. 2, insistence on sameness. The person exhibits an intensity on sameness, or insistence on sameness, inflexible adherence to routines, or ritualized patterns of behavior leading to extreme distress at small changes. Oftentimes, I just know from my experience, I can say more than anything that extreme distress at small changes tends to be very, very, very common in individuals, both children and adults, that have ASD. Fixated interests. So the individual displays highly restricted, fixated interests that are abnormal in intensity or focus, such as a strong attachment to unusual objects. Unusual objects on this, I know it's kind of a loaded term. I have seen some kids where they may be really fixated on something like a piece of paper, a bag, something like that. You think, oh yeah, well, a lot of typical kids will do that. Well, a child with ASD may hold on to that piece of paper, that bag, for days on end. And if you take it away or they lose it, they'll lose it. They will really kind of break down. Fixated interest, I mentioned one, right? Kids playing on the playground, maybe Legos. Legos seems to be a really common fixated interest for a lot of young children with ASD. And then the 4th possible component of this behavioral patterns under criterion B in the DSM is sensory reactivity. So hyper or hypo reactivity to sensory input or unusual interests in sensory aspects of the environment. So hypo reactivity is that you're not responding as a typical neurotypical individual would. So oftentimes, that can be something like blaring loud music, and the child may not be really reacting to that at all, whereas a neurotypical child probably would be crying, upset, doing something like that. Hyperreactivity is the opposite, right? So this is where a child will be really, really responsive, or an adult really, really responsive to some kind of sensory input. So for this, it can be something, as small as where a child, when they're in a crowded place like school, will just kind of have a meltdown because all the talking, the noise, things like that, they just can't process, they can't think, even though it's what maybe a neurotypical person would just consider to be a regular level of noise. So remember, this is criterion B, right? Only 2 of these must be present, not all 4. This kind of gives you a little bit of an idea of how it's a spectrum of disorders, right? Some kids, some adults may be really strong on the sensory reactivity. Maybe they have a little bit of this insistence on sameness, maybe not too much stereotype behaviors, and maybe some of this, right? Another child or adult may be really strong in stereotype behaviors, a little bit of this insistence on sameness, but no issues at all, no difficulties with like what would be considered typical sensory reactivity. So it just kind of gives you a little bit of an idea. Now, it has to be at least 2. Are there children that have all 4? Yes. But they only need to have 2 in order for a diagnosis to be made. All right. So going back, social communication deficits. All of those that I just mentioned, all 3 of these have to be present. That's criterion A. Criterion B, repetitive behaviors. That's the slide I was just on. Only 2 of these must be present for a diagnosis to be made. Can be more, but must be 2. In addition to that, in addition to those features, right? Remember, I said this before, the symptoms had to have started in early childhood, right? If an adult all of a sudden out of the blue started to develop those symptoms, we're not diagnosing them with ASD, right? An adult may have not been diagnosed, but then that's where we talk about the currently or by history, right? So we'd look, well, did this start when you were a child, right? Maybe we talk to family members, mother or father, and try to see when it started. The symptoms had to have started early on in life, had to start in early childhood. Clinically significant impairment. I'll talk about this towards the end of the presentation, but the symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. That is a component that goes into just what a disorder is, especially with mental health disorders, right? It's what's called a harmful dysfunction. So if I have hypersensitivity to sound, if I have kind of a fixated interest in certain things like Legos, I have difficulty with communicating in social settings with the social reciprocity. I mean, all these criteria. But you know what? I'm living a really great life. Like, I do have some friends. I have family that care about me. I don't really want more friends. I don't feel like this is interfering with my ability to go to school, to have a job later on in life. An argument can be made then that you don't have the disorder because it's not actually causing you harm in your life. And this is true of all mental health disorders, right? Anxiety. Say I have a phobia. This is actually true of me, right? When I was a kid, I was bit by a snake. I had a horrible phobia of snakes. If I saw a snake, if I saw anything that reminded me of a snake, I would panic immediately. But, it's not like I'm working as a, snake tamer at a zoo. I don't work at a pet store. I don't really hardly ever see snakes. Maybe occasionally I'll see one outside or something that reminds me of it. So is it really a disorder? It's not significantly impacting the way I live my life. Now, of course, side note, I'm not phobic of snakes anymore. I got help with that. But you see where I'm going with that, right? You can make the argument it's not really a disorder if it doesn't cause that big disruption in your life. So clinically significant impairment. And then the final criteria E, exclusion of other conditions. So these disturbances, right, all of A, at least 2 of B, these symptoms started in early childhood and they cause significant disruptions. All of those are not better explained by intellectual development disorder, which is intellectual disability. It used to be called something else before. Or global developmental delay. So both of those really refer more to a genetic, strictly biological condition, that leads to cognitive impairment and intellectual disabilities, right? So if you have those, you really can't be diagnosed necessarily with ASD, although that is a separate thing, right? You kind of sort of can be, but the symptoms that I just described, I just went over, can't be caused by that, right? So you kind of see the distinction there. It's really confusing. All right, so I went over this. Specifiers. So say you have autistic spectrum disorder. You have autism spectrum disorder. I'm a clinician. I'm diagnosing you with this. In addition to meeting all those criteria, the DSM allows for what's called specifiers. So this is usually added on after the disorder. So I could diagnose you as autism spectrum disorder with the specifier of intellectual impairment or language impairment or genetic conditions or neurodevelopmental issues or catatonia. Right? So it's kind of added on. These aren't considered necessarily types, more so that they are ways of describing what I would call unique features of a person who has autism spectrum disorder. Not everybody who has a diagnosis of autism spectrum disorder will have a specifier. And in fact, I'd say, in my experience, most don't. So you see listed here, right? Intellectual impairment. ASD can co-occur with or without accompanying intellectual impairment. So I just mentioned that, like technically, if the symptoms of ASD are not caused from that, you can diagnose for both. But if you also do have one of those disorders I just mentioned and ASD, you would add this intellectual impairment at the end of it. To me, I don't think this is one of the most inclusive terms. It's kind of a stigmatized term, intellectually impaired, but that is the term that's used in DSM. So that's why I'm using it here. Language impairment. Diagnosis may include the presence or absence of language impairment, which impacts communication skills and social interactions. My experience with this is that usually language impairment is where it's significantly delayed, where, say, a child, is basically non-communicative and they're at 3 or 4, something like that. It's usually for children who are non-communicative. Genetic conditions. ASD can be associated with a known genetic or other medical condition, such as Fragile X syndrome or Rett syndrome, influencing the diagnosis. So this is where they could add that, and it wouldn't be genetic conditions. It would be autism spectrum disorder with the specifier of whatever the specific condition is. Neurodevelopmental issues. The diagnosis can also involve associated neurodevelopmental, mental, or behavioral problems, which complicate the clinical picture. We'll talk a little bit about some of the co-occurring disorders, which are separate from specifiers, because with a co-occurring disorder, it's where a person actually meets all full criteria for 2 separate disorders. But I'll get to that in a second. Last one on here is kind of interesting. So it's catatonia. So in some cases, and I would say from just what I know about this, which isn't saying I'm an expert, I know everything about it, but just from my experience, from what I know, catatonia tends to be extremely rare with ASD, but it's interesting. Another interesting little tidbit here. So some cases of ASD may be diagnosed with catatonia, which is a condition characterized by decreased movement or excessive and peculiar movements. Catatonia is typically one of the features of schizophrenia. Not everybody with schizophrenia will have it, but there is a certain segment that do. So oftentimes with catatonia, what it says with decreased movement is that some people will literally kind of hold almost like a statue pose for prolonged periods of time. Some people, although we don't say this with autism, are non-communicative. So with schizophrenia, there's no language impairment portion of that. Like there's no language impairment specifier. So sometimes people who have schizophrenia who are catatonic will just not speak. They have the ability to speak, they just won't. With autism, we don't include that because we have the language impairment specifier that's separate. But sometimes what you see is those kind of decreased muscle movements where they won't really be doing stuff, they'll just be holding a pose. Or sometimes where they just kind of do movements, but they're very like herky-jerky and kind of not typical. And usually, I'll just throw the word out there, right? When you see it, it just looks extremely bizarre. And that would be a catatonia specifier. Alright, severity. Remember that the DSM is very distinguished from the ICD in the fact that it clearly defines levels of severity. The ICD-11 doesn't. It just kind of says that clinicians should kind of describe in detail the impacts. So I'll give you an example of this, right? So for language, say you're a child, or I'm a clinician, I'm seeing a child that has autism spectrum disorder, they do have language deficits. If I was using the ICD-11, say I live in Canada or some other country that primarily only uses that manual, I would just describe what language impairments they have, right? So with language specifier, child only uses short phrases, had delay in first word and other language milestones, right? Just kind of be very specific in describing it. And what would be needed. However, the DSM would just kind of label it, right? So it'd say language impairments at a level 3 or a level 2 or a level 1. Now, the way this works is at level 1, you can kind of think of, we talked about this in prior lectures, as being the high functioning. Level 3 is the low functioning, right? So a child, an adult who's at level 1, may need some support, right? It's not that they don't need any help at all, but it's very limited, right? So level 1, the definition there is without supports, deficits in social communication or some other impairments cause noticeable impairments, difficulty initiating social interactions. Individuals may appear to have decreased interest in social interactions. So not where they need a ton of help, but maybe where it's just something that a counselor, whatever therapy they're getting, whatever intervention they're getting, just needs to work on it with them, right? But it's not like around the clock. It's not like they need residential treatment or anything like that. It's just something they're working on for them or her, not a huge disruption to their life. Level 2 is requiring substantial support. So this is sort of in the middle between the high functioning and the low functioning. With level 2, there's marked deficits in verbal and nonverbal social communication skills. Social impairments are apparent even with supports in place. And restricted repetitive behaviors interfere with functioning in various contexts, right? So these kids, these adults are ones that they're going to need a little bit more help than what somebody would need at level 1. So maybe the child's already getting help at level 1, but it's not really working, so they need a little bit more intensive therapy, intensive training, intensive interventions. Level 3 is the lowest of functioning levels. Oftentimes we refer to that as requiring very substantial support. So these children and these adults oftentimes have very severe deficits in verbal and nonverbal social communication skills, cause severe impairments in functioning with very limited initiation of social interactions and minimal response to social overtures. So oftentimes these are kids that really need intensive help in order to kind of mitigate some of those deficits. Now, typically the way this works is that, I have certainly seen it where a person is just diagnosed and kind of referred to as, autism spectrum disorder level 1. But usually the way it works is that those levels are used to be more specific to what individual, right? So let me actually go back here. Say somebody does have severe deficits in verbal and nonverbal social communication skills, right? So these are kids that maybe are completely non-communicative at all, non-verbal, and even their non-verbal communication isn't really what would be considered typical and is kind of hugely disruptive, right? But so that'd be like a level 3. But maybe some other thing like their ability to initiate interactions or something else is a little bit higher, so they could be labeled like a level 1 for that, but then a level 3 for something else, if that makes sense. Generally speaking, just from what I've seen, usually if they're a level 3 for one of them, they're probably a level 3 for all of them. But sometimes too, I think this is where it's easier for clinicians to do that. And then again, one of the big kind of controversies with the DSM with ASD is that these are arbitrary levels. It doesn't really describe exactly what the child is capable of or what they're doing or what help they need. It's kind of pigeonholing these kids into these arbitrarily designed levels or categories. All right, so in the DSM, there's additional information that's listed. So you'll see that criteria. I just went over all the criteria. I went over the specifiers. I went over the severity levels. In addition to that, several pages where the DSM covers ASD, there's a section that deals with diagnostic features. So what diagnostic features are is, in my way of explaining, is it's just sort of like a synopsis, a narrative of what the disorder actually is. So the DSM outlines various diagnostic features of ASD, providing criteria to identify and diagnose individuals accurately, kind of like maybe what they would present as, what the typical case would be. It does include information about the prevalence of ASD. Generally speaking, I'd say most of the information in the DSM for disorders like ASD tend to be a little bit older, because think about it, right? They only publish new editions every 5, 6, 7, 8, 10 years is maybe the longest. But research in ASD is constantly being developed. So sometimes the prevalence rates maybe not be the most up-to-date information, but there is a listing of the prevalence in there. Development in course. So ASD symptoms typically manifest in early childhood, but they may not become fully evident until social demands exceed limited capacities. It is very common that oftentimes children with ASD, especially sadly those in lower socioeconomic conditions, poorer individuals, may not have as full access to medical care, that their parents may not see the early symptoms. So what happens is, the kid isn't diagnosed early, but then they go to school, and now all of a sudden they have all this exposure to different social settings, and maybe it's like really obvious now that the child may have some dysfunction, may have some concerns. So that's what we're talking about with the social demands exceeding their limited capacities, is that now they're in a setting that like, oh wow, now it's obvious that there's some kind of a deficit. And then associated features. So ASD is often associated with various features, including intellectual disability and other developmental disorders, influencing the overall presentation. So associated features, the DSM does talk about it. That is a separate module that we'll be going over in this class, as well as just kind of like the main features and how to work with somebody who may have ASD, how to help them with processing these certain features that they may have. Risk and prognostic factors. So genetic factors. Heritability estimates for ASD range from 37% to 90%. This is straight out of the DSM, indicating a significant genetic component in the etiology of the disorder. Etiology, for those who don't know, important other term for you to know, etiology means the cause, and usually it's used in reference to a disorder, a disease, something like that, is etiology. So again, that's a big range though, 37% to 90%. DSM isn't always up to date with the most cutting edge research, but that's kind of why they put that big range in there. But even at 37%, I can say that's a pretty high genetic component. And of course, we'll talk about the biological genetic factors of ASD, actually I think in the next module after this one. But we're pretty confident that there is some biological component, some genetic component. Environmental influences. So advanced parental age, so having a mother or a father that is older, can increase the risk of the child having ASD. Extreme prematurity. It sounds weird to say that. So a child that's born preterm. And in utero exposures to drugs or teratogens. So a teratogen is any substance that can cause harm to a child when they're in the womb. That can be a whole host of different things. Usually teratogen is used just to refer to substances, right? So that can be medications. This is why expecting mothers shouldn't take certain medications. It can also refer to things like alcohol, tobacco, are known teratogens. Some people even use that word more broadly, to be anything that can cause disruption. So say severe stress could be a teratogen. That's kind of controversial though. Typically when you hear that word teratogen, it means an actual substance. One thing that the DSM mentions, and there have actually been a few studies that have looked at this, is a prescription medication called valproic acid. I think the brand name is Valproate. I'm not positive on that, but the generic name is valproic acid. Has been linked as potentially playing a role in leading to higher rates of children whose mothers took this medication with having autism. Valproic acid is, and I may be wrong on everything it's used for, but it is used or has been used in the past for bipolar disorder, for treating bipolar disorder, and seizures. And those are the two biggies that I've seen them used for. There may be other uses for it. I'm not a medical doctor. I'm not a pharmacist, so I can't sit here and list everything that it's used to treat, but I know those are two big ones. And as far as bipolar disorder, it's not too common to be used anymore. An intellectual developmental disorder. So the presence or absence of associated intellectual developmental disorders is a crucial prognostic factor with functional language by age 5 being a good sign for individual outcomes. Again, remember, if all the symptoms I mentioned are caused by the intellectual developmental disorder, then you can't diagnose ASD. But if a child has intellectual development disorders and those aren't causing the disruptions to all those social things, then you can have both diagnoses. Sounds confusing? It is. But just make sure you know that. Language impairment. Language impairment is another important factor. The ability to communicate effectively is linked to better prognostic outcomes in individuals with ASD. Basically, the earlier we're able to get a child communicating, the better their outcomes are when they have ASD. And there is a very real reason for this, is that, remember, the big social impacts that ASD has. A huge part of social interactions is just to be able to speak, to communicate verbally with other people in order to help the child, to teach the child so the child can learn. Most of the time we're kind of living in a world where it's verbal. So all those things help with the outcomes when the child's language abilities are more intact. And then finally, comorbid conditions. So comorbid conditions, and epilepsy is one of the most common. We'll talk about that later in the semester. Epilepsy tends to be pretty common with children with ASD. But there are other disorders, mental health disorders, things like anxiety, depression frequently occur in individuals with ASD. Children and adults who have comorbid conditions, so comorbid just means another disorder that kind of tends to be more common if you have ASD. Those individuals who do have these comorbid conditions oftentimes have more challenging outcomes than individuals who only have a diagnosis of ASD. All right, cultural and diagnostic issues. So it's not mentioned specifically in the section on ASD, but the DSM does have a section in the hundreds of pages that constitute it that talks about cultural influences. So this is important to note because so much of ASD and the criteria talks about social interactions and what's considered typical or appropriate social interactions. The problem with this is that you also have to factor in that when you're trying to determine if a child is typical for their social interactions or not, is that element of culture. So cultures are very different all around the world. And even though you say, well, we're in the United States, well, a lot of people in this country come from different cultures also. So you always have to kind of ask yourself, is this typical for their culture, but it may seem bizarre, odd, weird for me? And you kind of see that a little bit more on the second bullet point here. Traits like quietness or introversion may be seen as normal or typical rather than indicative of ASD in some cultures. I can tell you one of the most common attributed signs, early symptoms, early signs of autism in the United States is avoiding eye contact, right? A young child avoiding eye contact. Now, granted, young children like infants, toddlers aren't really culturally influenced yet, but I can tell you that in early childhood, in Asian countries, in middle childhood and adolescence, it would be considered very disrespectful for a young child to look at an adult in the face, to look at them in their eyes, especially an adult in a position of authority. Like if you're going to see a doctor to diagnose you with something, right? They may kind of look away. And that's just their way of showing respect. Obviously, other cultures, that's not the case. In the United States, I don't really think that's a big thing unless you come from one of those cultures, one of those backgrounds. So I'm just using that as a for example. So you always have to kind of ask yourself, even though this may seem bizarre, weird, odd, atypical, maybe for that child or that adult's cultural influences, their background, it's typical. Stigma and awareness. So this is the other thing that culture kind of plays a role in. In some cultures, in some countries, ASD may be very highly stigmatized, leading to reluctance in seeking evaluation or care. I would even argue in the United States, even though we diagnose ASD all the time and times have changed dramatically in the last 20, 30, 40 years, there is still some stigma and a lot of misunderstandings of ASD. And indeed, some families, even though they may suspect their child may have ASD, because of a variety of different things, religious reasons, cultural reasons, biases, stigmas, they may never go get the child checked to see if they have it and get them the interventions they may need. Limited awareness of ASD in certain regions. I can say, most of the Western world, most developed countries, there is pretty high awareness of ASD. I can't speak for every part of the world. I can speak for part of the world that I've been in. I know throughout Latin America, throughout Europe, throughout North America, and throughout Asia, Australia, New Zealand, there is high awareness of ASD. But in many other countries, there tends to not be. And probably the one example that comes to my mind is historically many people in sub-Saharan Africa oftentimes are unaware of this disorder. Again, it still exists there. It's not like it doesn't exist in those countries. It's just not a lot of awareness of it, not a lot of recognition of it. Misconceptions about ASD can perpetuate stigmas affecting individuals' access to support services. So one of the big takeaways I hope all of you get from this class is that you are helping to limit that stigma, right? And you may never know when it actually happens, but through knowledge, through learning, through understanding, through embracing this disorder, you can be part of the solution by helping to fight some of that ignorance. Differential diagnoses. So this is still staying with the DSM. In the DSM, it will mention what's called differential diagnoses, and these are actually oftentimes really helpful. So what a differential diagnosis is I'm a clinician, I'm thinking this child may have ASD, may have autism spectrum disorder. The differential diagnoses are other suggestions of what the diagnosis could be, right? So some of these are really close, and basically it's sort of the DSM's way of saying, before you make a diagnosis of ASD, consider some of these disorders and make sure you rule them out before you make that diagnosis, because they can share some features. It can be kind of close, and I can tell you for some of these things in the DSM, it can be kind of difficult to distinguish them. So these are some of the big ones. These are the ones that are in the DSM. ADHD, attention deficit hyperactivity disorder, is a differential diagnosis. Now, a child and adult can be diagnosed with both, but the symptomology has to be pretty clear, and they have to fit all the criteria for both of them. And in fact, I'd say ADHD is pretty common with individuals with ASD. Intellectual development disorder, I already kind of talked about that. Language disorders, there's a whole host of different types of language disorders listed in the DSM. So you have to look through those, and of course what would be the deciding factor there is also like the social impairments and some of the other things. Selective mutism, stereotypic movement disorder, and anxiety disorders. I'll say anxiety as a whole with children and adults with ASD tends to be very common also. So you can be diagnosed with anxiety disorder along with ASD, but you kind of have to look at the symptoms and say, well, is this kid not wanting to go into social settings? It doesn't want to talk because they have really high, maybe social anxiety disorder where they don't want to be around other people, they don't want to be in public. So that's where you would rule it out. Now, of course, a child, an adult, could have both also. But that's what the differential diagnoses are all about. Comorbidity in ASD. Remember, comorbidity refers to another disorder occurring along with a disorder. Incidentally, in the DSM, this can be two mental health disorders. In the DSM, that's usually what they're referred to. But in the larger scheme of things, it can be a medical disorder with a psychological disorder and vice versa also. So, for example, people with high anxiety or with an anxiety disorder oftentimes also have cardiovascular problems. So, comorbidity in ASD. About 70% of individuals with ASD may have one comorbid mental disorder, and 40% may have two or more mental health disorders. And of course, the presence of a comorbid disorder does make the outcomes a little bit more challenging for individuals with ASD. Some of the common mental health disorders are anxiety, depression. I'd say anxiety is probably number one. ADHD, very, very common with individuals with ASD. It's not on here. Actually, it's on the bottom. Medical comorbidities, epilepsy. We'll talk about it again. Very common, especially in children with ASD. And then other associated conditions. Avoidant or restrictive food intake disorder is a frequently presenting feature of ASD. So oftentimes part of that, restricted interest and behaviors is that children, especially young children, may only eat like 2 or 3 things. I know I have one person that comes to my mind, one young child, that would only eat tater tots and hot dogs, right? And that's it. And you probably think, well, every kid's kind of like that for a while. It's like, yeah, this kid was like that for like a year and a half. And getting them to eat anything besides tater tots and hot dogs was a war, right? That was a battle. So it kind of gives you an idea. That tends to be very common with children with ASD. All right, so that's pretty much diagnosis, assessment. When we're talking about assessment tools, really what we're talking about is like tests, what we're actually using, what instruments we're using to help us in making this diagnosis, right? Not just the criteria, not just the DSM, but if there's some kind of, objective test that we're giving. The gold standard for assessments for ASD is an assessment tool called the ADOS. I've heard this pronounced ADOS. I've heard it pronounced ADOS. ADOS is what I'm going to say. So it stands for Autism Diagnostic Observation Schedule. This is generally considered to be the gold standard of diagnosing with ASD. It involves a clinician directly observing, interacting, testing the child directly. The other 2 main assessments are the ADI-R, which stands for Autism Diagnostic Interview Revised, and the CARS, or Childhood Autism Rating Scale. Both of these can be administered fairly young. Both of them, though, kind of largely involve talking to the parents or caregivers for the child. Whereas the ADOS, oftentimes, even though we'll also talk to parents, talk to caregivers, is based off of direct observations. And again, the ADOS is really kind of the gold standard. It's what, as far as my understanding is, what a lot of insurance companies are going to require in order for a diagnosis to be made. As far as who can diagnose, you all should at this point know the difference between a psychiatrist, a psychologist. Remember, psychiatry is a medical profession. It's a medical specialty, so these are medical doctors that specialize in mental health. They can definitely diagnose. Psychologist is somebody who has an advanced standing degree, doctorate in the field of psychology. They are allowed to do assessments and to make diagnoses. And of course, this depends on what state you happen to be in. I know in Florida, medical doctors, especially pediatricians, by law are allowed to make the diagnosis of ASD. Technically, so are licensed clinical social workers, licensed mental health counselors. But there's a caveat here, folks. Generally, for pediatricians, for mental health counselors, nurse practitioners, things like that, to make a diagnosis, they need specialized training in it. So legally, they may be able to make the diagnosis, but it's not really going to matter for anything if the insurance companies reject it. And that's usually what ends up happening. So unless you have the specialized training. Psychiatrists, psychologists, those tend to be the ones who make most of the diagnoses. So what happens is usually a child, right? It's almost always children at this point that are being diagnosed, are referred to a psychologist or a psychiatrist that specializes in ASD and diagnosing and assessing it. One of the reasons why it's so important, I talked about insurance companies. So if you remember way back in Module 1, ASD is actually one of the most expensive lifetime, over the course of a person's lifetime, one of the most expensive disorders, medical conditions you could have. as of 2015, so obviously the price has probably gone up. Think about how much prices probably changed that you can remember from 2015 to 2024, 25. But in 2015, the average was about 2.4 million per person over their lifetime with what that costs. So that's both like direct medical expenses, lost income, things like that, expenses put on society, put on the family, over that child, that adult's lifetime. That's a lot of money. In addition, interventions, therapies, what children in particular need that have ASD in order to help them with their functioning is ridiculously expensive. So on average, an ABA therapy session can range from $120 to $150 per hour. ABA, if you remember, stands for Applied Behavior Analysis. It uses operant conditioning, classical conditioning techniques to help children, especially with things like social interactions, things like that. So without insurance coverage, the cost of ABA therapy can range from $240 to $600 per day, $1,200 to $4,800 per week, and $4,800 to $20,000 per month. That's a lot of money. And incidentally, right, if insurance is footing the bill for it, this is the reason why insurance companies are very particular on who's making that assessment, who's making that diagnosis. So they don't really care that legally an LCSW can do it. They want to know that this is somebody specially trained, that has received certifications in it, that specializes in it. In order for them to end up having to foot the bill, that could be very expensive. Speech therapy, likewise, right? And ABA and speech therapy generally are like the two main gold standards for interventions for children with ASD. We'll talk about them later in the semester. But the average for speech therapy can range from $100 to $250 per hour too. That's a lot of money. Occupational therapy. A lot of times children with ASD, even adults with ASD, will see an OT, right? That's another $100 to $200 per hour. So you can kind of see just how expensive this can get. Now, it's worth noting, some states do offer help for parents that have children with autism, with ASD. Some states pay for screening. Florida doesn't. One of the states off the top of my head, I know California does. They allow for one free assessment for every child born in that state. Because, to be perfectly honest, even though we're talking about the expense here, we're talking about the lifetime expense also for that child, that adult. Early detection is key. So the earlier you detect that there is concern for ASD, the earlier these interventions, OT, ABA, speech therapy, can get involved and help mitigate the problem. Understanding disorders. So this is something I kind of did talk about before. The APA, the American Psychiatric Association or Psychological Association, defines a disorder as a group of symptoms that cause significant distress or disability. These symptoms can be behavioral, psychological, physiological, and reflect a dysfunction in the mind, body, or in typical development. I'm saying this again because remember, we're talking about diagnosing here, we're talking about assessments, we're talking about all this stuff, but remember, you need to have that harmful dysfunction, right? If you don't have that, you don't have the disorder. So a person can be very neuroatypical, right? But if they don't have that disruption in their life, they won't get a diagnosis of ASD. And undoubtedly, I can say just from experience, you listening to this, 100, 150 people, usually my classes for this are about 100 to 150. I'm sure there's more than a few of you are like, oh my God, this is ticking some boxes for me, or a friend or a family member. I think they have ASD. Maybe they do, maybe they don't. This isn't the avenue to diagnose them. Maybe you yourself are like, I see a lot of symptoms here that maybe kind of strike close to home. Well, you can have them, but if it doesn't cause that severe, significant disruptions in your life, then you're not really falling into that category of it being diagnosed. But then that kind of gets into some of the topics we talked about in Module 1 as far as neurodivergence. That isn't an actual diagnosis, but refers to people who just neurologically are atypical. They don't fill that typical mode but they're able to carry on with their lives relatively fine. Another term that oftentimes is used in clinical settings is called autistiform. So autistiform refers to basically the neurodivergence, right? So this term may be used to refer to somebody who's neuroatypical but doesn't meet the criteria for ASD, for autism spectrum disorder. And of course, this kind of brings in a lot of different cultural issues because it goes back into that idea of is it important? I guess is the first thing, right? Is it important to know that I'm neuroatypical if it's not causing disruptions in my life? Is this just another label that we can throw on people? And who knows? In the end, maybe in the next version, in the DSM-6, autistiform will be a disorder. I don't know. They've certainly done things like that before. If you remember from the lecture I did on the history of ASD, the DSM varied widely from not recognizing it to recognizing multiple different types of it to then saying, no, it's all just one disorder. So who knows what the future holds. But definitely kind of interesting little thought experiment of just trying to figure out where you stand and what your beliefs are on this. All right. So that is it, folks. Hope you enjoyed the lecture. Take care, and please let me know if you have any questions or concerns.